Thank you so much for having me here. I'm really excited to share some of the work my colleagues and I have done and have been thoroughly enjoying the conversation in every one of these sessions. So I'm a hospitalist at Penn, a former associate CMIO there, and I've spent the last 15 years focusing on designing technology to better support our clinical workflow, specifically around safer communication so that we can make less errors. My work in this area has, and its success has led me to launch a business to try to get our tool into other people's hands. So this is my disclosure. So we've talked a lot about documentation burden on clinicians. There's been great chat about what burden means. And similarly, I wanted to make the case that documentation matters, that it has value. It is an important form of communication about what happened, why did it happen, what do we want to do about it. But importantly, and I think we also honed in on this on the chat, is that it's really about critical thinking, and the process of thinking through our plan is a very important part of patient care, as long as our tools support that process instead of make it more difficult. We know there's many workflow mismatches that currently exist and lead to many different types of workarounds in how we deliver care, including, I believe, the beloved patient list, which I'm pretty sure every clinician carries around, but perhaps is actually in and of itself a workaround for the fact that the chart doesn't give us a quick, concise summary of the most salient points we need to know about a patient at the point of care. Instead, it feels kind of like this long, endless row of books that we have to pour through, maybe with a card catalog, and it's certainly not portable, at least not portable enough, leaving us hanging when we need to make decisions at the point of care. So as a workaround, we're forced to make these Cliff Notes versions of our charts that we carry around with us as a rounding list, as a handoff, or some other paper that we stuff in our pockets. And from a documentation perspective, I'd like to point out that there is valuable information trapped on these papers that often never makes it back into the chart because it takes too many steps. So we haven't fixed paper workflows. We actually looked at how much paper we were printing at Penn. We were printing 22 pages per patient per day just for rounding lists. We also know that the half-life of these printed documents is about 3 hours, but we were carrying them around for 9 to 12 hours a day. So making decisions off of old and inaccurate information. And the reality is the way we're delivering care is constantly changing. My entire field of hospital medicine has cropped up because instead of seeing patients once a day, we need to see them hourly because plans are changing so frequently, sometimes minute to minute. And yet our tools have not caught up. Yes, I do think there's an element of romanticizing paper and we're much better than we were before, but I don't think the change has been enough because the paradigm is still very much around what a paper chart was. So we have systems that started with coding, billing, and other regulations, and we've kind of built on top of them piece by piece these different components as they've been identified as what we need. And it's become very duplicative. And we write the same thing in multiple different places, but wouldn't it be nice if this was the construct of how our charts work instead, where we have one plan that feeds into all these different workflows and documentation artifacts? So that's where our project took us, to reimagine how documentation is written and communicated, not focusing on what can be done within the limits of the EHR, but what we can do to make it better. So we mapped out what our flows usually look like. On the left side here, we have all the different components of information about a patient that we want to know. And on the right side is where we often write them or read them. And you can see we write the same information in all of these different places. Then we have our papers at the end of the round, at the end of the day, where we've written information and need to incorporate that back into the story. We have our handoff paper that we've written. So it's no wonder that we're frustrated and confused and our documentation is never up to date. So we approached this from the perspective of what if we created a communication hub, a workspace where all of these pieces of information that we need to know clinically are represented, but that is a collaborative, dynamic, living workspace, a wiki, with semi-structured elements that can then be sorted and filtered and changed around based on what your workflow is at the time or what documentation you need to create. And importantly, making sure that you can access it in real time and update it in real time instead of having to annotate paper and then remember to update it when you're back at a computer. So we created CareAlign, an internal project to solve this problem. At the time, we didn't have hospital-issued devices, so we built it as a mobile web app like a Fire plugin, like we've been talking about, to the EHR. And that is an essential thing here, is that it's EHR agnostic. We had Cerner, Allscripts, Epic, all sorts of different systems that we needed to connect to, as well as device agnostic. And very purposely built this to be cross-discipline and cross-specialty. To start the design of our product or our solution, we started with what we had on paper and really sorted the data into two different types of data: objective data that we thought should be able to come from the source systems, and then qualitative information that we were writing as clinicians and working on throughout the day, and then reorganized it really to kind of look like a note with all the objective data in one easy to access place, and all the qualitative information organized into a problem-based or issue-based plan. So this is what it looks like in our platform, where on the left side you have vitals, labs, meds, all this information coming in real time from whatever the source systems are. So we don't have to spend time writing that on paper. And then we have our plan on the right. I'm going to go through the different components here, which is busy, but it really does illustrate that you can have all these components in different views. So this is the wiki view, which you can use for pre-rounding, rounding, for generating the content of your progress note. You have your patient demographics, your summary statement, which also becomes the assessment statement of your progress note, a place for your initial presentation or hospital course. And you can also do your hospital course by problem. I like to do that in my discharge documentation. And then you have active, resolved, and inactive issues. So this is how we used to organize that on our paper. And then within each section, you have your problems that you can organize and reorder. And for each problem, you have your plan and the tasks. So it sounds like a lot of pieces, but again, this is all those different columns in the tables that we normally print. And I realized that a lot of the information we write in our handoff, or that we write in our rounding list, or that we verbally tell each other, are things that we're already thinking about when we're rounding and we're writing our progress notes, like anticipatory guidance that we need to know about a patient, or discharge planning elements. And instead of having free text, by having it semi-structured but easy to use, we're able to then pull that information out and cross-reference it for different workflows. We have primary tasks and covering tasks. So then we can sort that and view it in different ways. So when we start with a progress note, we create an action, they create assessment and plan. It creates a note builder where you can choose what you want to bring in, and then puts all of those different components together for you with the subjective, the objective, the assessment and plan. And then if you're in a paper progress note world in your hospital, you can then print it and put it in a chart, which is how we started off. Or if you're in an electronic world, then you can integrate into the EHR, which we do in the sidebar of Epic, or we had it in Tab and Sunrise. And similarly, you would open your progress note builder right there, and then using a dot phrase or copying and pasting it into your progress notes. You can still keep and leverage the progress note templates you've already made, but use this to generate the clinical content part of your note. So that same information, it can now be viewed to get our work done the rest of the day. So this is like the rounding list or the task view by for your whole list. You have different patients here. Within each one, you have, again, the summary, the demographics, you have anticipatory guidance, you have tasks. Everything here is editable. You can add new ones and complete them. And then there's just, with one click, I can get to the evening or the handoff view, which shows the night task, or the discharge view, which shows all the things that have been flagged as being related to discharge. So did our experiment work? I would say yes. We had very rapid adoption and steady engagement throughout the health system. So on the top here, you have, starting in 2015, when we first launched, the initial adoption at Penn broken down by role. So this monthly logins, which is about, now it averages about 160,000, 150,000 a month. And you can see it's really interdisciplinary, which is one of my favorite things about this project. We've implemented at another community hospital, also with some trainees, but also that steady engagement there. And when you look at the actual care plan edits at Penn, for example, this shows that when we were on Allscripts and we first implemented, again, steady uptake, and then it was pretty steady usage. When we implemented Epic, there was definitely a change in the usage because we went from paper to electronic notes, but it has leveled off, and it really is still a very integral part of how we do our documentation, how we do our handoffs and rounding with 1 minute.
Yep, 1 minute, Subha.
Okay,
yep.
Thank you. So similarly in the closure system, where they are using this as a, I didn't mention this before, a completely standalone application, not integrated to their EHR, and they're on paper progress notes. They have also similarly had really great adoption and engagement of the application. There's always challenges. I could probably spend an hour or two just on this slide, but I'll say quickly that one of the biggest ones is just change, right? People are extremely busy and doing anything, even if it's a better workflow, is hard. My key there has been designing for delight and really making sure that I'm listening to the user and doing something that makes their jobs easier. As I mentioned, I made this an interdisciplinary universal tool. So nursing, pharmacy, surgery, medicine. There was some initial territorialism over that, but that actually faded very quickly once people saw all of the things that were being lost in translation between the different services and errors that were being prevented. And then I'm going to skip to the last one because I think that might be interesting for discussion later, which is the biggest challenge I think has been a cultural one. That, is it okay to have a documentation tool outside the EHR? Some people's concern was, are you going to then miss things and not get it into the EHR? But we actually found that we had more complete notes because we were capturing things that were otherwise not making it into progress notes. But it's a culture shift. It's a different way of thinking about things. I think on this call, we all have been talking about that, but not everyone is ready to embrace that. And I'll leave it on this slide because this is what drives me. This is my passion, and this is why I'm doing what I'm doing every day, because users and the clinicians and the residents who I do this for have said time and again that it's made their jobs easier. It saved them half their time documenting. They understand their patients better, and that's what keeps me going. Thank you.